This is a case report about a Cushing disease. So this would be a neurosurgery case. Today we'll know more about Cushing's disease. So what is Cushing? Or more, who is Cushing? Cushing is a neurosurgeon. It's called Harvey Cushing, who in 1910 firstly discovered that case where a patient was suffering from certain signs and symptoms that were related to a disturbance in excessive corticosteroid production. Alright, so Cushing's syndrome is the thing that happens due to prolonged exposure to glucocorticoids or corticosteroids, and it's a rare disorder that affects from 0.2 to 2 persons per million worldwide. The age of diagnosis with Cushing's syndrome ranges from 20 to 50 years of age, and female to male ratio is 3 to 1. The main causes of this syndrome, one of the main causes is pituitary adenomas. Now, the thing is, when it's an endogenous cause inside the body, it's called Cushing's disease. And when it's exogenous, for example, due to prescription of corticosteroids like prednisone, dexamethasone, so on and so forth, it's called Cushing's syndrome. So the case that we have today is a Cushing's disease case. So that means that it's related to something inside the body, the pituitary gland. Now, the pituitary gland is one of the most important glands of the human body, and it secretes something. The anterior part of the pituitary gland is responsible for secreting a hormone called adrenocorticotropic hormone. This hormone stimulates the adrenal glands to secrete more corticosteroids. So, when there is an adenoma, which means that there's a tumoral formation at that part, we get more and more secretion of ACTH, and that leads to abnormal signs and symptoms like weight gain and fatty tissue deposits, which is moon face, so we got a puffy face, buffalo hump, which means that we get a fatty deposits at the back of the neck, we get pink or purple stretch marks or stria, we get slow healing of cuts, insect bites, acne, so the skin is affected. For females, we get hirsutism and disturbed menses or amenorrhea, which means that the menstruation doesn't occur. And for males, we have decreased libido and erectile dysfunction. So the patient that we have is a 40-year-old female patient that presented to the neurosurgery department in January 2018 for control. If you look at the timeline of the progression of the disease in the patient was diagnosed with a cellular tumoral mass. It means that there's a tumor in the sella turcica right there in the pituitary gland, based on MRI findings, and that was in December 2010. After that tumoral mass, because it's present in the cellular area, it can press on the optical chiasm, and this can cause optical problems. So the ophthalmologic checkup reveals that there is a slight papillary edema on both sides of the eye, disturbed visual reflexes, and the patient was operated through a transnasal transphenodal approach, which means that this is the first way to treat pituitary adenomas or resect pituitary adenomas in Cushing's disease. Alright, so through the sphenoid sinus, the pituitary gland is resected. This can be done through two ways. We have endonasal, which means through the nose, and we have a endolabial, which means that it's done through a cut through the lip, and the probe is inserted to resect the adenoma through the pituitary gland. Our patient had an endonasal endoscopic approach. Post-op, so after March 2011, control MRI showed that there is a tumoral relapse along with a small right frontal cavernoma. Cavernoma is an abnormal arteria formation that happens due to the presence of the tumor. So that cavernoma is also a tumoral formation. The patient performed a protective bilateral adrenalectomy. We said that the adenoma secretes ACTH that stimulates the adrenal glands to produce more corticosteroids. So also another way to control Cushing's disease is to remove the adrenal glands. The patient went through that as well, even though afterwards there was another tumor relapse. So the patient later, after 6 years, she presented again to the hospital with, again, visual disturbances, pituitary insufficiency, anxiety, depressiveness, and all of that is due to the pituitary adenoma. And again, the MRI showed that there is a frontal subcortical lesion along with a cavernoma that was previously stated. So she went through a third type of treatment, and that is gamma knife radiation therapy or stereotactic radiation therapy. So that one is done through that. There's a helmet that the patient puts. It's fixed to the head through certain nails, and there is around 192 probes that direct radiation to remove the tumor. Even though it's called gamma knife, it's not actually invasive. It's totally done through radiation, and the cavernoma was ablated or removed through the gamma knife surgery. And in January 2018, the patient presented for control. There was no tumor relapse. She presented a relatively ameliorated visual performance and a follow-up treatment including lifelong intake of prednisone. Now, prednisone is the corticosteroid because the adrenal glands are not there anymore. The pituitary gland has a part of it removed, so the patient should be supplied by corticosteroids for lifelong intake. Now here we can see a couple of MRIs done through here we can see the tumoral formation right there, and right here as well in the sella turcica. So those are the cross sections. Now the special, and also here, this is in January 2018, an X-ray done for the patient. The special thing about this patient is that she went through almost all the treatment options that are used for treating Cushing's disease currently. So the guidelines of Cushing's disease treatment consider surgery as the first line treatment with a remission rate of 65 to 85%. So most of the patients that go through these treatments, so 65 to 85%, they ameliorate, but there's about 20% risk of recurrence. So right now, the surgical treatment for Cushing's disease is kind of doing the job. It's not perfect, and we still have to look to other ways to control the disease. And yeah, that's it.